coming up next on Functional Moms Podcast.
And when she's saying, I don't want to take this therapy because I'm going to suffer, what is she thinking about? Is she concerned about like the breast cancer suffering? Is that what we're specifically speaking of?
So many patients don't take hormone therapy because they're petrified of breast cancer. And when we look back at this study, we saw the women who were on estrogen alone, there's two hormones that they studied, estrogen alone, and that was for the women who did not have a uterus, and then estrogen and progesterone. They saw that with this synthetic estrogen, women actually had lower rates of breast cancer when we look back. So there's so much that we learned about this study that was confusing and mislabeled when it came out that we've learned now that is actually not so bad. And so when women hear that, now they say, wait a minute, I can take it. I thought if I took this, I was going to get breast cancer. And obviously, anytime we meet with a patient, we talk about their personal history, their family history, any kind of risks before we go ahead and give them hormones. Things have changed a lot since 2002.
Welcome to Functional Moms Podcast, lifestyle medicine for women over 40. Let's age on our own terms.
This episode is for you if you want to look and feel your best during perimenopause and menopause. We are going to find solutions for all the common complaints: hot flashes, weight gain, poor sleep, declined bone health, vaginal dryness, and more.
Our guest today is Dr. Ann Yehl, a board-certified physician with over 25 years in healthcare. She is passionate about women's health and owns Coastal Women's Health and Wellness, a New Jersey practice that focuses on preventative care and health promotion.
We were thrilled to be a part of Dr. Yehl's Women's Health and Wellness Night in Ocean, New Jersey. And I was super inspired to see so many women come out on a freezing cold January night to learn how they can up-level their health. For too long, we have been given little information and solutions when it comes to menopause.
Dr. Yehl, we're so excited to have you on the show today. We'd love to start off by having you tell our audience, what is perimenopause and menopause?
Sure. Thank you so much for having me. And I'm really excited to be here talking to you. So perimenopause is defined as the spot before menopause, and it can be anywhere from a year, 2 years, to up to 10 years. So this is a huge period of women's lives. I mean, when we think about 10 years before we have our last period, menopause is defined as the last period, and it's really a retrospective diagnosis. So I can look back and say, okay, if my last period was a year ago, no bleeding, that's when my menopause was last year. So it is hard because you don't know when it's coming, because you keep watching and watching, and some people will go a few months. But during perimenopause is when we really see the fluctuations of hormones. Estrogen and progesterone are not doing their normal thing. Our whole lives as women, since puberty, we've had a very regular fluctuation in estrogen and progesterone, causing our period to come every month, allowing us to get pregnant. And during this phase, everything is off the grid, up, down, in, out. And that's really what's the cause of these erratic symptoms.
And you're saying that could last as long as 10 years? Is that what you said?
I know.
Yikes.
I hate to even say it, but that's why it's so important that we see a healthcare provider who's really well versed in this so we don't have to suffer through this time. And not to say that everyone suffers. Some people, it's just a blip on the radar. But for a lot of us, it's a tricky time.
Yeah, I love how you said, and the key thing is to find a healthcare provider that can guide us during this time, because I really think that's one of the current biggest challenges. However, while I'm saying that, I also am starting to see a shift. I'm starting to see that people like yourself are stepping up to fill in the gap. So, like, the question is, what are traditional doctors missing when it comes to perimenopausal and menopausal women and their health?
So that's a big question.
Mm-hmm.
And I probably should start by backing up a little bit. In around 2002, a study was stopped, the Women's Health Initiative study. And this was a very large study looking at multiple things, but it had many women from like 50 to ages, I think think 75 of all different medical backgrounds. And these women were placed on hormone therapy. Some women were in the control group. And the study was abruptly stopped because they found an increased risk of breast cancer and some blood clots and other things. This came out in 2002, petrified every doctor, petrified every woman. Every woman was ripped off HRT. You're going to die if you take this. And a lot has happened since then. We've looked back, we've looked at that study, we've seen it was very flawed in many ways. The
Mm.
data was a little bit misrepresented. So, as we look back and we look at the data, we've learned so many new things in terms of that study. But the barrier is that if you were a patient or a doctor who was learning or in residency and training in 2002, you thought if you gave your patients hormone therapy, you were just going to kill them. It was absolutely the worst thing you could do.
Wow. Yeah.
So, anyone trained during that time period or who was practicing during that time period who has not really dug in and looked at the data from that study since then and all the new studies in the last 25 years is really kind of stuck in that mindset. And even we see it on the patient side. So, when physicians are saying, I'm not going to prescribe hormone therapy because it's harmful, we see that flip side. The patients will say, I don't want to take hormone therapy. I'm going to suffer because it's harmful. So, there's a misrepresentation really on both sides, doctor and patient.
And when she's saying, "I don't wanna take this therapy because I'm going to suffer," what is she thinking about? Is she concerned about, like, the breast cancer suffering? Is that what we're specifically speaking of?
So many patients don't take hormone therapy because they're petrified of breast cancer. And when we look back at this study, we saw the women who were on estrogen alone, there's two hormones that they studied, estrogen alone, and that was for the women who did not have a uterus, and then estrogen and progesterone. They saw that with this synthetic estrogen, women actually had lower rates of breast cancer when we look back. So there's so much that we learned about this study that was confusing and mislabeled when it came out that we've learned now that is actually not so bad. And so when women hear that, now they say, wait a minute, I can take it. I thought if I took this, I was going to get breast cancer. And obviously, anytime we meet with a patient, we talk about their personal history, their family history, any kind of risks before we go ahead and give them hormones. But things have changed a lot since 2002.
And I'm just gonna throw Kristen out there. How about someone like Kristen whose mother she has a family history, her mom had breast cancer?
That's a great question. So, a lot of physicians will say, absolutely not. Family history, you're out, you're done. Just suck it up. That is not the new thinking. And when we look at new data, we say, wait a minute, hold on. That's actually not the case. So, we look at the data, we look at what kind of breast cancer your mom had, if it was hormone positive, we look at any genetic testing you've had, if you're getting mammograms, if they've been normal, and then we assess your risk based on that. But it is absolutely not a straight no answer. It should never be a straight no answer, no matter what medical conditions you have. We really should take the time to assess and look at the data, the newest data that's been out in the last 25 years about cancers, about heart disease, about, strokes, all the different, things that can be benefited or harmed by hormone therapy because there are a lot of benefits from it.
Wow.
So I'm hearing it's a really nuanced conversation, individual for each person. This isn't like some kind of blanket recommendation for each woman.
You're exactly right.
Okay. And so I guess for someone even like me that has a family history of breast cancer, I guess what makes me nervous about it too is just the environment that we're in, we have all these like plastics and estrogen and endocrine disruptors and all that is adding to the confusion. So what are your thoughts on that? And then the HRT and all that mixed together.
So you're right. I do have a lot of patients who are, very scared about breast cancer, who are, putting plastic in the microwave, who are getting those Starbucks cups and drinking hot coffee from microplastics every day, who use all the BPA chemicals, who are drinking alcohol every week or every night, all these different things, who are obese, who smoke, all the different environmental and external factors that increase your risk of breast cancer way more than hormone therapy.
Mhm.
So I think it's really, again, it's a nuanced conversation. It's looking at the whole picture.
Mm.
And unfortunately, that takes time. So when most people go to their provider, what do we have, 15, 20 minutes at most?
Right.
It's
Sure.
really hard to check all those boxes. Do the breast exam, do the pelvic exam, talk about healthy habits. Oh, you're having symptoms? Okay, well let me quickly go through them and assess your risk. And that's truly why I do what I do and have these enormously long visits because it takes so much time to go through and dig through all of the family factors, the environmental factors, because they all can put you at risk.
Right. That sounds like a
Absolutely.
really gratifying job too, just to connect with individuals in such in at that deep level and just like it's just so cool. It's like you're really making such a huge difference. I'm really curious, Kristen, how does that make you feel listening? Just because I know we've had this discussion, like listening to what the Dr. Yale's saying, like how does that make you feel about the possibility?
I mean, it definitely makes me feel more hopeful and more in control
Mm,
because when I've had a conversation with, for example, my GYN, like at my annual appointment, it was just sort of like, sorry, this is the way it is. There's nothing you can do, that you shouldn't be looking at HRT because your history of breast cancer. I was told I probably would end up with osteoporosis given my frame. Like it wasn't a very positive conversation and it was very short to your point.
right.
I mean, she must have spent about 5 minutes with me and then it was out the door.
And to add to that, she also told you, no, you asked her, well, should I get like the bone density testing or
And she said, "Oh, no, you're much too young. We'll wait until you're older." And then I was like, "Well, wouldn't it be too late then? Like, I don't even see the point." So, yeah, the whole conversation was kind of just confusing and really not helpful. So, and I think this is the common scenario for a lot of women. I think this is what they encounter. I don't
yeah,
think
I had a
that
similar experience as well. That's why we're asking you that question, like, what are traditional doctors missing when it comes to perimenopausal and menopausal women? And because of this, and I'm sure that this is probably more than not.
Definitely. That's why I have a practice. My
Yeah.
patients all have other doctors and they're looking for answers and they're looking to be heard because other doctors don't typically have that time. And so that's really where I have just filled in the gap
Yes.
because patients are not in an ideal world. When we were 35 or 40 going to the doctor, we would get a little information. Hey, by the way, in the next couple years, these are some things to look out for. These are some things you can proactively do right now to optimize your health before you get to this period of your life. And nobody even gives us that heads up. Hormone
no.
therapy is going to be an
Yeah.
option,
I was going to say, I never got that talk.
right?
No, and actually you're making me remember when I was 40 and I went to the GYN, I said like, "Oh, I'm 40 now. Like are things going to be Oh, no, you're much too young. No, you'll be like this for a while." Like so there was no heads up. That's your point. Like we had
Right.
no idea.
And then for me, I was at my gyno and I was 52, around that ballpark range. And I said, I'm experiencing X, Y, all the stuff. And she's looking at my chart. She's like, wait, how old are you again? And I said, I'm 52. She's like, oh, yeah, you're fine. That's normal. Meaning all the things that I was talking about, that's normal. And you're basically just shit out of luck. You're right in it. You're exactly where you're supposed to be. And there's not a thing you can do. Hey, work out like but nothing. Like not even the basic thing. Never mind, HRT. But I was like, wow. And honestly, at the time when she said that to me, I didn't even question it.
No.
I
Yeah,
was
why
just
would
like,
you?
oh, okay. Actually made me feel good to know that my shittiness of how I was feeling was normal and that I was okay.
Right.
It's so sad. And it's not to say that people who are treating women are not doing a good job.
Right.
They're in a very difficult spot because they have very little time with a woman to talk about all this. With kids, we talk about anticipatory guidance. Like when your child is 2, you talk about what's going to happen at 2.5 and 3 so you can hit those milestones. We don't do that with women. We know in puberty, we have milestones that we hit. And when we have young girls and they go to the doctor, we say, okay, these are the things that are going to start to happen. But we don't really have that in perimenopause and
No.
menopause. And a lot of our mothers were told you just suffer through it. And we're learning now so much new data, like the increased hot flashes. Women who get a ton of hot flashes have a higher risk for diabetes. That's a really important thing to know.
Wow.
And as a woman, I would really want my doctor to tell me that and to say, not just you're normal, these are the symptoms, but they can put you at risk for different things and you don't have to suffer. This isn't a time where you have to say 10 years of your life is just going to suck. I mean, that's not fair. It shouldn't. And as I tell my patients, perimenopause and menopause treatment is kind of like going to a Las Vegas buffet. You have your hormones in this corner, and then you have your compounded, you have your bioidentical, your synthetic hormones. Then you have a whole other buffet of medicines and supplements and things that we can do to treat those symptoms so that you're not miserable. It's so important to go to someone who can spend the time and the energy and who has that knowledge to say, these are normal symptoms for where you you are in life, but let's fix them because you shouldn't walk around having, hemorrhaging, yourself out every month or anxious every day or depressed or, skipping work because you're having such bad hot
Or
flashes.
sleepless nights.
Sleep is one of the biggest
Yeah,
things
I
because
know. I talk to a lot
it's
of women that
oh,
can't sleep at night or they wake up continuously and it's just so hard and then it screws up your whole day. And I love that point that you made when you said, our healthcare providers, it's not like this my gyno was just like, "Oh, let me just completely screw Raquel over right now." I wonder like why did she say that to me? Like she said it wholehearted like she was just like that's what she believed. Like I don't know if do they not have that type of education? Do you know what I mean? Like why are they like why did Kristen's doctor say that to her? Like do they not have the same type of information or is it that someone like you went into greater depths to learn more about women's health and the stuff that they learned when they were in medical school was just skimming the surface, just like kind of touching base on it but not going into great depth?
right. So, no matter what your specialty is, you get 0 to a tiny bit of training in menopause. Even
Mhm.
in OBGYN residencies, maybe it's an hour. It's
What?
kind of the joke going around because this is a huge I mean, you're spending like half of your life in
Yeah.
perimenopause, menopause, and there is just nothing on it. And I can say it's until you really dig deep, you don't get that information. And I
Okay.
can tell you, even training, I trained as a nurse midwife and a nurse practitioner in women's health prior to going to medical school. And it was just skimming the surface. Again, it was probably that hour. And when patients came in, it was like, are you suffering? Okay. Do you have vaginal dryness? Okay. Well, if you're really uncomfortable, we can give you this estrase cream. And now we know, wait a minute, everybody should be on this. What are we, what are we doing? But I'm sure you've
Mm,
seen around there was an Instagram thing saying, I was a bad menopause doctor. And really, everyone's a bad menopause doctor until they take the time to study the new data and to really dig in and learn about it because
right,
there's no residency in menopause that we
right.
all learn from.
And I
So
guess if they have to see so many patients, to your point, where do they have the time to, I guess,
Right.
re-educate themselves? And, that's difficult.
Hmm.
yeah. Now they can refer everyone out to, Dr. Yale.
Yeah.
But, it's great. I'm so happy that we, like, tapped into this because this is, like, the root cause, I think, of the issue that the average woman out there is having with her primary doctor, right? Like, she's feeling things and he's like, "Oh, yeah, you're normal. Oh, okay. Oh, good. I'm normal. This is normal." And it just sheds so much light. I just think about that woman that I was and the woman that I am today. And just from being more proactive about my own health, I was able to do better for myself, and I'm older now than I was then. And I'm feeling better now because I'm doing certain things that help me to a certain degree than, back in my former year, back in when I was 52. So, yeah.
So I guess could you explain a little bit what hormone replacement is? Because I think there's confusion on
Yeah.
that too. And are there different, like I know you mentioned synthetic, and then I know there's the bioidentical. So
The
if we could
buffet.
just go through a little of that, that would help.
Sure. So hormone replacement therapy is, any form of when we have a deficiency or a loss of hormones, putting them back in the body. And sometimes you're trying to get it to higher levels, sometimes you're just trying to get it replaced just so you're not having symptoms. So like for example, if you have a thyroidectomy where you have a thyroid that comes out, you have to replace thyroid hormone. You really need that for your body. And the traditional views are that when estrogen and progesterone, take a nosedive, we just leave them alone
Hmm.
and that, women can just kind of see how it goes. That's a lot of it, see how you feel. But now we learn, I mean, estrogen receptors are just saturated the brain. They're on almost every organ in the body, which is why we have so many symptoms. We don't just have loss of periods when we go through menopause. Every organ is affected, our skin, our brain, our hair, our nails. I mean, everything, heart palpitations. So, anyway,
Yeah.
we like to think about it in more just replacing it to just a dose where people are comfortable. So you're not trying to replace it so that you're having 20-year-old levels. So that's essentially putting back hormones in the body. And you can do that in a few ways. You can do that through hormones that are synthetic, like birth control pills. You can take those during perimenopause or some of the oral hormone replacement. supplement, those are 100% synthetic, and your body sees those as something a little bit different. You're still able to process them, and they still are replacing the hormones that you're deficient in. Bioidentical are a little bit different. They still are made in a lab, no one's digging them out from the ground, but they are called body identical or bioidentical because your body recognizes them because they're a different form. So your body sees them as exactly what they produce. So it's a little bit easier to take in. And those forms are what we use most in practice. So that's the estrogen and the progesterone that you would get from most doctors. These are FDA approved medications. A lot of times patients will come to me and I'll say, we're going to use the patch and we're going to use a pill. And they'll say, well, where do I get it? Like I'm sending them to some witch doctor basement, that they're mixing it up in
Uh-huh.
their little pestle. But I mean, you get these from the regular pharmacy. These are all FDA approved, the bioidenticals, and you can take them in a bunch of different ways. I really like the bioidenticals that are patches, rings, gels, sprays, because they don't go through the liver. The oral medication goes through the liver. So then you have a little bit of a different absorption and a different clot risk, which is much lower. So most of us who are in, very focused in menopause medicine stick to the bioidentical lane. And of course, we can veer out of it, if a patient has different needs. But so we have synthetic, we have bioidentical, and then compounded. And that's really for someone who has a different issue. For example, patients who are allergic to peanuts can't take progesterone. They have a reaction with the micronized progesterone. So we have to get them something different. So sometimes they want to try compounded. Or patients who have an allergy to the tape or to the film in the transdermals. Sometimes we have to do the bioidentical or the
Is
compounded.
the compounded like, I'm picturing the mortar and pestle thing,
Yes,
is that
that
okay,
is,
so
that is,
okay, okay.
yes. I mean, most of us have, like, 1 or 2 compounding pharmacies that we rely on that we know are very highly regulated, but they're not FDA approved.
Okay,
So, that is a little bit different.
I see. Okay, so it sounds like there's a lot of options, and you said you really go on the symptoms the person's having? Is that how you judge your dose? Because
That's
that's okay,
exactly it.
okay.
So,
Because it
for
wouldn't be one dose for everyone, because like you said, everyone's so different.
right. And some people, based on their symptoms, might need a little more estrogen or a little more progesterone. But if someone has a uterus, you have to do both estrogen and progesterone.
How do you decide which type are they gonna, the synthetic, the bioidentical? How do you decide which route to go in?
So it's a really good question. And it's really based on the patient's symptoms, their history, and their family history. And so, I usually start with the bioidenticals just because of the decreased risk in some of the factors. So, based on your symptoms, I usually look at what dose of progesterone, of what dose of estrogen, and then kind of go it from there. And it's a little bit of a playing, we go up, we go down. Some people have side effects, some people don't. So we do, it does take a little bit to tweak the dose to the perfect dose, but it's pretty quick in terms of seeing it work.
Wow. And so would you say that HRT is necessary for optimal health in menopause?
So, if you are not risked out of it. So, for a woman who is extremely high risk, who's had, breast cancer, hormone positive, who's had several strokes, things that I would maybe say, all right, these are some concerning symptoms. Obviously, I wouldn't give that patient hormone replacement therapy, but does putting the hormones back in your body make things work better? Yes.
Okay.
Yeah, so that's another thing. Like we had actually from Instagram Wise and Well on our show a while ago, Maria Claps and Kristen, right? And they talked about how they feel that almost everyone should be on it because of the benefits to the bone health and you're reducing your cardiovascular, disease risk down the road. But the question is, what if you're having no symptoms? Like if you don't have hot flashes, you don't have brain fog or sleeping issues, then would you really say that those people should be on it too, just to prevent all these diseases down the road?
So it really depends on your risk. You talked about bone health. So let's go there for a minute. I don't know if you saw, but we have a US preventative task force and they just looked at the DEXA scan or the bone densities. It typically now we start at 65, which at 65, oh my gosh, right? That's like you're so far gone at that point for most people. And I was excited that they were looking at this again. And when they came out with the outcome, it basically said, we're going to leave this as it is.
Ugh,
And I thought, "Oh, come on,
yeah.
really?" But it's the greatest good for the greatest number with the least cost.
Mm. Right.
I don't look at things that way, at least for
Mhm.
my patients. So,
No, we
um,
wanna be optimal here. We don't
yes,
wanna be just getting by, like
right? So you wanna check the bone, early, 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 especially if you are thin, especially if you're
Right,
Caucasian, especially
exactly.
yeah, family history, like, you wanna know that,
It's just a no-brainer. I don't understand. It's like,
right?
let's wait till the worst happens to then be proactive
and
about
then
it, to
it's
do
too
something
late.
about it.
Yeah.
You know that
Right.
that's probably coming. Like, you could see like, okay, like for you, she said you have the like for Kristen, she
My
doctor
doctor
said
s
you have
she
the
said,
frame for
"Given
it.
your
You have this,
frame." Yeah.
you're probably gonna get
Mhm.
this. Well, then, it should be like, okay, you need to get this test so that we can start working on that now.
Exactly. So if you were my patient, I would say, let's get a bone density. I'll say you have a family history of osteoporosis, as you
Mhm.
probably do.
Mhm.
Of course, only if you do. And we'll try and get it covered by your insurance. That being said, if we can't get it covered by your insurance, it's really not like an expensive test.
Yeah.
And if we
How
know
much
that
how
you're,
much would you say that test is about
think it's like
out of pocket?
$150. It's
Oh, that's
Yeah.
really,
not,
it's
yeah.
not a killer.
Right.
Right.
So, I mean, most women who are, paying that for a gym or for Botox would would
Yeah.
say, "Okay, let's do it. This
Right.
is really gonna help me," and get a baseline so that I can say, "You know what? You're starting to lose bone, so let's be aggressive with calcium, let's be aggressive with vitamin D, and let's get you on a very good weightlifting regimen to really optimize your bone and your muscle so that you don't end up with osteoporosis."
Yeah. Yeah, I mean, that makes so much sense. It's disheartening that I was told, "Oh, yeah, you're probably gonna get it," but, "Oh, no, we're not gonna check till you're 65." Like,
Yeah, and we're not gonna recommend anything for you, but again,
no.
this
Yeah.
takes time, right? This takes time for me to say I can't just say, "Go lift weights." I have to really explain that to you. I have to
Mhm.
send you to a trainer. I have to make sure you're doing it right so you don't get hurt,
Yeah.
and all those things take time.
Yeah, and you know what? I have to jump in on that because you referred someone to me, a woman to me, and she started training with me. And she said her biggest thing was she wanted to get stronger, she wanted to work on her balance and the concerns about her bone health and such. And I think we're 3 weeks in now. I was just with her this morning. So she is doing wonderful. And so thank you so much for referring her to me and even for herself. Like she already looks, we were doing some things today and she said to me, there is no way that I would have been able to do this on day one. It's so amazing how quickly your body just starts honing in. Like once you start focusing, and it's amazing how your body just like that's the instinct. The animal instinct is to protect, to be like it wants to be the best. And
Right.
you gotta be in alignment with that. So, that was very, 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 very cool. And, we're talking about bone health, so what are some of the things specifically that we can do to improve bone health after menopause?
So, nutrition, that I think is one of the biggest things. And,
Mm,
most of my patients, to be quite honest, I think not just bone health, but just overall health, we really need like a team. It's not
Mhm.
just me, it's really a team of people because all aspects, like all the pillars of health, have to be addressed for living a good long life, right? We can live a long life and we can live a good life, but to live a good long life where we're not in the nursing home, stuck in bed, not able to get up or do anything for ourselves are
yes.
two different things. So, in terms of bone health, I like to get a baseline assessment. I like to look at muscle mass and I like to send patients to a trainer who really knows how to work with menopausal women, right?
You never
Because
tell.
it's very nuanced. I mean, if you're going to a trainer who's 18, who just got their personal training certificate, and you're saying, eat less, move more, well, those rules don't apply in perimenopause, menopause. And you're really looking for a different type of training. It's not really about being skinny, it's about being strong and it's
Yes.
being agile and that balance training and really getting your body to move in different planes without falling over. And I think that's a mindset that might be a little bit more tricky for someone who's very young to grasp. So that's really one of the first things that I do is training because you have to build muscle mass because we know muscles protect the bones. The more muscle you have, the less likely you are to fall and get hurt and break something. But that also comes from nutrition because if you're starving yourself and you're going to the gym every day, well, who cares? Your body is just going to eat up all that muscle. So nutrition is a huge part of it and being able to learn what fuels your body. So not just looking at, again, being skinny, but looking at
Right.
how am I nourishing my body so that I can build muscle muscle to make it really last long. It's like putting good gas in your car.
Right.
You don't want to do it, but if it helps with the longevity of your car, it's probably a good investment.
Right. It's not just thinking about calories in, calories out. You're looking at
Exactly.
what types of calories are you getting in? How are you nourishing your body?
Mhm.
And I like how you're tracking. I mean, you're saying, I'm going to send you for a scan. I'm going to look at how your bone health is because most of us have no clue. We don't even know what we're starting with.
Right. Well, and it's lucky now because we see a lot of fitness companies who will actually be able to do that tracking of, I mean, not just bone, but of muscle. So
Yeah.
it's really rewarding if your patient can do it. And some gyms even have like the InBody scales where
Oh, yeah.
you can start pre exercise, before you start a regimen, and then a few months later follow up and you can actually see the gains. Or
Yeah.
you can do the body scan, the body composition scan, and you can see that the visceral fat that we all tend to put on in menopause goes down because of the actions that we're doing. And that is just, I mean, the most wonderful positive feedback you could possibly get.
Yeah, we would like to ask you about the weight because that is one of the biggest complaints we get from our listeners saying that this weight is just creeping on during perimenopause and menopause. They are not doing anything different. They're exercising the same, eating the same. Like, what is going on?
I know it's so hard because as physicians, we are told, eat less, move more, and that will take off the weight. And that applies for most of life, and as young people, often we would say, I'll go train for a marathon if I'm going to eat French fries and hamburgers every day. And it would work. But once you get to perimenopause, that stops working. And glucose metabolism changes, insulin changes. We often become more glucose resistant. So we notice hemoglobin A1Cs, which looks at our blood sugar, tends to creep up a little bit. Sometimes our insulin creeps up a little bit, and we start to gain this belly fat. People who, come to me say, I've always had big legs and now my legs are tiny, but my belly is so big. And, I can't put in my pants anymore. And I don't understand because I'm exercising, I'm eating right. And it's so frustrating. So for those patients, we do the same things. We do optimizing nutrition during menopause and really shifting the focus to protein. Definitely fiber and protein are huge components. And again, I love when my patients will go to a nutritionist and really sit down because almost everybody thinks they eat well. And when you really dissect it, you say, how much fiber are you taking? Oh, I get 25 grams. And when I actually look, I'm like, you're getting more like 10.
Mhm.
It's a big difference, and especially for colon health and for weight loss. So it's really good to sit down with someone who really knows what they're talking about, who can kind of dissect your diet and not make a meal plan for you, but give you an ideas of the foods you can eat that will sustain your body, but that won't be stressful for you and you'll still be happy.
Yeah, that makes a lot of sense. And I think, we've had a lot of guests on too saying even if you just track temporarily what you're consuming, it's very helpful information because to your point, we kind of underestimate how, much we're really eating. And then we also, the fiber, like if you're not counting it, you really have no idea. The protein too, it's very hard to just guess.
Absolutely. I have a food scale and I decided a few years ago when I, of course, was in the same spot, same exercise, same calories, managing stress really well. And all of a sudden, this weight started to plop on. And, I got a food scale and I'm measuring my chicken and I'm thinking I'm eating all this protein. And when I actually weighed it out, it was so much less than I thought. So I think it is really useful to get some kind of an objective measurement just so we have an idea. So that then, not to be tracking calories or, stuck on an app all day, putting every morsel in it, but just to get a good idea of nutrition to optimize protein and fiber and water. And then, of course, exercise. We have to talk about exercise. We have to talk about weightlifting, about, interval training. We've got to get people away from the 45-minute cardio,
Mhm.
those really intense long sessions that aren't really beneficial to us in menopause. So really kind of flipping that around and saying, you don't need to run on the treadmill for an hour anymore. Let's take that out and give you that time back and focus it maybe on weightlifting. And, the more muscle you have, the more calories you're going to burn at rest. So optimizing, muscle, optimizing diet, optimizing sleep, optimizing stress management. And then when I go through all those things with my patients and they're doing really well, or if they're already doing those things and they're saying, gosh, nothing's working, that's when we really dig into the labs and look at insulin and we look at glucose
Mm.
and we look at other options because sometimes you need a little medicine to kind of push you over. And some patients, really want that. And I get it.
Right. And, just to peel back when you were talking about measuring your food, and because then you realize, wow, I thought I was getting this and I'm actually only getting this. I just want to tell that woman out there that she's like, oh my gosh, that's so much. But you don't have to do it forever. If you just scale out your food, just let's just say it gives you start understanding, oh, now I know. And you don't need that scale anymore. You're able to give yourself the portions that, because then you educated yourself on what works for you, like through scaling, through using the scale, for example, measuring your food so that you understand exactly what it is that you're actually getting.
You're exactly right.
And then what are your thoughts on the all the GLP-1 agonists now that are available and the medicines? Like, do you think that's a good tool for us in the perimenopause, menopause place?
Absolutely. I think it's, again, a tool in the toolbox. I think first you want to optimize those other things that we talked about. And, I do see patients who say, I just want that. And in previous practices where I was, seeing patients every 15 minutes, I did have a lot of patients on the GLPs and they weren't weightlifting, they weren't looking at diet, and they'd go off them 6 months later, they'd gain all the weight back and they'd want to try them again. And it was so unsettling for me. I do prescribe GLPs now, but I do it in a much more prescribed way. Like if you're going to do a GLP with me, then you have to do the whole package. It's not just here's the injection, good luck. It's we got to talk about weight. We got to talk about nutrition. We got to talk about exercise. We know that there can be a significant loss of muscle,
Right.
which
Mhm.
is exactly the opposite of what we need to happen at this stage.
Which then affects your bones.
Right. So, I mean, that's non negotiable for me. And, we really need to check labs. A lot of people are prescribing, you get online a GLP, you see them every 6 months. No way. Like, we need to check labs. We need to make sure your pancreas is good. We need to make sure you're absorbing it. We need to do bone densities. We need to check your body composition. And it's really more of a program than a prescription.
Right.
Yeah, I love
No
that,
quick
yeah.
fix.
No, yeah, it's part of a comprehensive program, which is great. So we also wanted to ask you about hot flashes, what women can do about that.
Don't suffer through it. That would be my
Mhm.
first thing is recognize that yes, this is a normal part of perimenopause, but that you don't have to suffer through it. I mean, we know as we talked about before that it can put you at a higher risk the more you have. It's
A
very
higher risk
disrupting
for.
for diabetes.
Diabetes.
Okay,
For
because I was
diabetes.
actually just speaking to a woman this morning at the gym, and she was just telling me, she was complaining. She's like, just having these, I guess, sweating. She's like sweating like at night a lot. She's like, it's terrible. She's like, I'm constantly sweating all like at night. Is that a hot? I don't think I've ever suffered from the hot flashes. So
Ooh,
is that what a
lucky.
hot flash is the sweating?
So a hot flash can be typically when they're at night, we call them night sweats. But is it the
Okay.
same thing? It's the same thing.
Okay, it is the same thing.
It
Okay.
can be during the day, it can be at night, and I mean, there's really negative consequences all around. I mean, at night, certainly it's incredibly disruptive for sleep. We need to sleep a good 7, 8 hours. And when we're getting up, and
Mhm.
not just getting up, we're having to do something. We're having to turn the fan on, change the
Right.
sheets, change our clothes. I mean, some women are soaked from these. It's
Wow.
very, very disruptive. But
Wow.
during the day, it's the same thing. If you're in a work meeting and you all of a sudden get this really intense hot flash, often you have to excuse yourself. You have to go to the bathroom. You might miss half the meeting because of this. So it's not, I know it's a normal part of perimenopause and menopause, but it doesn't have to be prohibitive at night or during the day. There's certainly things that we can do to optimize our health and medications we can take,
Right.
supplements we can take that are even non hormonal that can make this better.
Mm, that's great to know that you can even do non-hormonal replacement therapy
Mhm.
solutions. That's amazing. And then can you just explain a little more about the diabetes link with that study? I've never heard of that before.
Sure. And I can certainly send you the study. But there was a study that came out just in the past year that was showing that people who had more frequent hot flashes had an increased risk for diabetes later in life, which is, I think, really significant because again, we
Yeah.
tend to, as women, just suck it up, blow it off. If it's not ruining your life, don't do anything about it. But when we see it's correlated to something like diabetes, I mean, that's really concerning.
That is. Yeah.
So
Yeah.
Okay.
Just yeah.
just pay
And
All right,
attention.
good to know. Yeah.
I just want to add to that when you just said that, because I thought to myself, when you just said, so many women are like, blow it off, like, they got other things going on. Like, because the reason that we're doing that is because we usually are taking care of our family members. We don't like, we get a little thing like, oh, I can deal with it because I have, this 20 things that I have to do on my to do list. and we don't prioritize ourselves in this space. So then it would take something like the word, hey, by the way, that could be linked to diabetes. Be like, oh, okay, I'm going to actually do something about this because, it's like you have to like look at the wall that's coming up in front of you, like right there to prioritize the things that you're doing for yourself.
Absolutely. It is a good time for women to kind of reevaluate, like, how do I want to spend the rest of my life? What am I doing for self-care? I mean, nobody, knocks on your door and says, "Are you meditating? Are you taking time for yourself? Have you gotten your hair done this week?" I mean, no, nobody checks in and makes sure, right, that we're taking care of ourselves. So we really have to take that time to say, what am I doing so that I can pick up
Yes.
my grandkids, so that I can still drive, so that I can still travel or, go out to lunch with the ladies or play golf or do whatever they do.
Yeah, love that. I love that. And see, like, I guess meditating, that's something that you can do to improve your sleep. Because we have a question here. What can we do to improve sleep during perimenopause and menopause?
So the meditation is one. The easiest thing is really good sleep hygiene. So,
Hmm.
after 12 o'clock, not having caffeine, not having a ton of liquid before you go to bed, making sure your bedtime is when your normal melatonin would spike. So, for most people, getting up in the morning, getting out in the sunshine so that we feed into our natural circadian rhythm so that around 9 or 10, we start to get sleepy. Not on our phones at that point, not watching TV, not doing stressful things, not chugging down water because we've been deficient all day, and really kind of having a wind down time at night in a cool, dark, quiet room, using an eye mask if you need to, using lavender on your pillow. I mean, there's just so many things that we can do to optimize our sleep. And certainly technology and phones and alcohol all feed into this.
Yeah. And I just have to say that as you're saying that, I'm thinking to myself, like, it's probably like this percentage that has that dark, cold room, like with that like perfect nighttime hygiene. Because you know that a lot of people they have a TV in their bedroom and they go to bed going to sleep with the TV on.
Mhm.
And I grew up like I no longer have a TV in my bedroom, but now you introduce the phone. That is very, very hard. That is very hard.
It is. It's a really hard habit to, be able to pack that phone away and not look at it again past a certain time. It's really tough. It's not easy.
Yeah, I would associate like, my chill time. Like this is I'm
Yeah.
finally in my room.
That's how a
I
lot
could,
of moms
right,
feel, I think. Like, you're like, "Oh, this is
Yes,
my, let me consume my junk food, whatever, which is on the phone." Like,
right.
yes.
my social media, like,
Yeah,
all
junk
that
food for the
stuff. Yeah.
brain.
Well,
Right.
unfortunately, we know that social media is not all positive messages, right? So as we start to see, we get on our phones, we look at the news, we get stressed out, we see other people doing things really well, we compare ourselves to them. It just kind of feeds on itself. So it's not like that relaxing, like if you were to get in bed and you were to read a book and
Such a
there's no blue
difference.
light, there's no bad messages, it's just reading a book and relaxing and putting your brain in a different spot, really telling it it's time for sleep.
Yeah. And I have to say, I did do an experiment myself where I made a commitment that I was just going to do a 5-minute meditation and like read or journal. Those were the three things. I can do them all, or I can do one. And I did it for a period of time, which I think I did it for like 5 days or something. And I did sleep amazingly better.
Mm,
I should have
yeah.
I'm gonna do that and the thing is like, why didn't I stick with it? Like and I do it more so now than I don't, but then I also fall off the wagon and I'll be, like, on my phone. I'll wear my, like, light blockers, the blue light blocker.
Mhm.
I'm trying to think like, "Oh, yeah, well, I'll just wear these blue light blockers." But there's so much more stimulation going on besides the light going into your eyeballs. It's like you said, all that mental stimulation, just in all different directions that you don't really have control over because you're scrolling and allowing any of that stuff you're allowing it into your brain.
Yeah. So it sounds like sleep hygiene is the biggest needle mover on this, but are there supplements and things that you find that help people?
Absolutely. So, yeah, sleep hygiene is sort of where we start, kind of like nutrition and weightlifting. So, once we can get through all those different sleep hygiene things and saying, all right, I've checked all these boxes, I'm really doing these things optimally, then we start to look at when you're not sleeping. Is it trouble falling asleep? Is it trouble staying asleep? And kind of hone in on those areas. And sometimes it's supplements. Some people do melatonin. Some people like magnesium. Some people just do lavender. There's a lavender pill you can take. And, not that I'm recommending any of these. I have tried most of them myself and do like them, but all different things work for different people. And it really depends on where the problem is and what the problem is. I have a lot of patients in perimenopause that wake up in the middle of the night, racing brains, can't get back to sleep.
Mhm.
And does hormone replacement work for that? It works so nicely for that, so
Okay.
well for that. I have so many patients who've had great success just changing
Mm,
that,
yeah.
getting better sleep and decreasing their anxiety from that. But there are tons of different things that we can talk about.
Yeah.
Mhm. Okay. And so we also wanted to ask about vaginal dryness because that's a common thing. I think as people get older, it gets even worse. And so we're wondering what are some options for that?
So, the first thing I would do is get used to lubricants and really recommending lubricants from anytime you've had a baby or you hit 40. It should just be, part of your normal routine anytime you're intimate
Mhm.
and kind of getting used to finding the one that you like, that you're comfortable with, that's non irritating, that you're used to. So, that would be my first thing that I would recommend. And then after that, during perimenopause and menopause, we know the vagina changes so much and the lubrication goes down into the toilet. Usually it's very, very dry. The folds of the vagina kind of tend to go away. The color changes, the elasticity changes. And right next to the vagina is the urethra. So those changes affect the urethra too, making us more prone to urinary tract infections and other urinary issues. So even if you're not sexually active, I think pay attention to vaginal dryness. And once you hit perimenopause, menopause, really start to consider using a local estrogen. So some kind of estrogen that goes in the vagina and stays within the vagina next to the urethra. And
And
that helps hugely.
that's something you would get prescription?
That's a prescription and it comes in a couple different forms, a suppository, a cream, it comes in a pill, a ring, all different kinds of forms. And that's local. So who could use that? If you have risk factors, can you still use that? Pretty much anybody can use that
Because it's not going into the bloodstream.
because it's really a local
Okay.
application of
Mhm.
it. Mhm.
Okay. And have you heard about people putting it on their face to have
Yes.
less wrinkles?
Yes, I have heard
Because I
about
have seen that online a lot, people talking about that. I'm just curious.
Yes. So here's the problem is that I really like to do things that have data backing it up.
Mhm.
I mean, there used to be estrogen in cosmetic many
Wow,
years ago.
really? Oh,
Mhm,
wow.
So we know that it works, but we don't know how much. Like, can you slather estrogen all over your neck? Can you slather obviously we can't do that, but who knows how much to use? That's the tricky part. And so I'm very excited to see data. For skin right now, I usually recommend Retin-A for patients.
Okay.
That's been the mainstay.
Okay. And what about like things like red light therapy? Does that have enough data behind it?
So there's some data on that, and I think it's not going to be harmful in any way. I think definitely try it, for at least a few weeks and see if you feel like it's improving your skin. And if you do, great, keep using it.
Mhm. That's another thing online. Everyone's got those masks on before going to
Hmm.
bed, the red light masks.
Right.
Does that help you go to sleep better, the red light?
No, I don't think there's any data on that in sleep. I think it's really
Okay.
more skin tone.
Okay. All right. Well, being mindful of our time today, Dr. Yale, we'd like to ask you what are two things we can do today to age strong as a woman over 40?
Great questions. So I would say, at the very minimum, focus on building your muscle. And I would focus on nutrition, on really eating to nourish your body so that you can live that way forever. Good foods in your body. Start now and just keep going on that great path.
Mhm.
Wonderful.
That's
Wonderful.
excellent.
You can connect with Dr. Yale, and that's spelled YEHL on Instagram. Her handle is at Dr. Marianne Yale, or check her out, her website, coastalwomensmedical.com. Thank you so much, Dr. Yale.
Thank you so much for having me.
Thanks. The information provided in this podcast is for informational purposes only and is not intended for the purpose of diagnosing, curing, treating, or preventing any disease. We are functional medicine certified health coaches and not licensed medical professionals. The opinions and advice of guests are their own and also not considered to be medical advice. Always consult with a healthcare professional when making any healthy lifestyle changes. We would love to hear from you. Please leave a comment or review. Email us at info@functionalmoms.com. If you enjoyed this episode, please hit the subscribe button.